All right, we're going to go ahead and get started with today's discussion. Again, welcome to today's specialty testing webinar on Kelch-like protein 11 autoantibodies. It's a novel biomarker of testicular cancer that's associated with neurological autoimmunity. My name is Kayla Erickson. I'm a product manager here at Mayo Clinic Laboratories, and I'll be moderating today's conversation and handling Q&A after we're done. So just a couple of things to remind everybody about before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the Q&A function, which is at the bottom of your Zoom screen. If you submit those during the talk, we'll hold those to the end and then we'll go through the Q&A afterwards. Today's program is being recorded and it will be posted to our website in a few weeks. So at this time, I'd like to just do a quick introduction of our speaker today. Dr. Devanshu Dubey is an assistant professor of neurology and assistant professor of laboratory medicine and pathology here at Mayo Clinic in Rochester, Minnesota. He has received the International League Against Epilepsy Clinical Science Prize and the Peripheral Nerve Society Arthur K. Asbury Inflammatory Neuropathy Prize. He has authored over 100 peer-reviewed articles in various high-impact journals and has been an invited speaker in multiple national and international conferences. His research focus is central and peripheral autoimmune neurological conditions. This includes the search for novel biomarkers and analysis of clinical and radiological features of autoimmune neurological disorders. One of those novel biomarkers is Kelch-like 11 protein, and that's the focus of today's conversation. Welcome, Dr. Dubey. We're very excited to hear from you today, and I'll hand the floor over to you.
Thank you, Kayla. And thank you all for joining me today for this talk when we discuss the clinical significance of Kelch-like protein 11. Through this talk, I might refer to Kelch-like protein 11 as Kelch-11 or sparkles. This is not the most scientifically correct way to name it, but still it's the common lab lingo we commonly utilize. These are some of my disclosures. I have patent pending for Kelch-11 and leucine zipper 4, and I've had some industry consultations as well. So the biomarker discovery and biomarker utilization has been something which has transformed our field of autoimmune neurology. And it's truly taken up speed in the last 25 years. So these were the biomarkers we knew of before mid-1990s, just a handful. But the numbers skyrocketed starting in late 90s. And many of these onconeural antibodies, many of these cell surface antibodies ended up being discovered. Our focus today is going to be on this biomarker Kelch-11 and slightly on leucine zipper 4 as well, which can sometimes coexist with Kelch-11. So as I go through the talk, these are the things I'll be talking about. How was Kelch-11 autoantibody discovered? Are there any clinical or paraclinical features that can help neurologists, other physicians who are seeing these patients for the first time, identify Kelch-11 encephalitis? Is this antibody useful in directing cancer search? Are these antibodies themselves pathogenic? Or is there a different immunopathogenic mechanism which is causing the disease in these patients? And how do these patients do over long term? Is this a responsive disease? Is it a refractory disease? We'll also briefly mention how I treat these patients when I see them in clinic. And most importantly, how are we testing for Kelch-11 antibody, given Mayo Clinic Labs is the only lab doing the testing for this antibody right now. So I'll start with a case. This is a gentleman I saw in clinic. He's a 38-year-old man working, and all of a sudden in summer of 2017, June, July, he started noticing some fullness in the ears, and soon after started noticing that he was developing a hearing loss. It started from one ear and soon transitioned to the other side as well. In about 6 months' time, it was not just hearing loss. He started developing some balance issues and walking became more and more difficult. And by May, so another 5 months, the walking continued to get worse. He started using a walker and he also started having trouble with his vision. When he looked to the right or to the left, things became double. He was seen at a local neurology clinic. MRIs were done, which came back to be normal. A lumbar puncture was performed, which only showed elevated oligoclonal bands, not a lot of inflammation otherwise. His samples were sent to our lab for testing, and then the patient was referred to us in our autoimmune neurology clinic to help understand what's going on. This is the video of the gentleman I'm talking about. And he describes what he's been facing over the last 5 months since the central nervous system got more aggressively involved.
And I couldn't keep standing up. I get practicing fall without some.
As you can hear, he's very dysarthric. So the presentation is not just limited to diplopia, ataxia, it's also affecting his speech significantly. It all localizes very well to the brainstem and to some extent cerebellum and brainstem region of the brain. His walking was also severely affected. And by the time he came to see me, he was already using a walker. As you can see in this video, even though it might not be the best representation of the patients I've seen, these patients have this initial hesitancy in starting the gait, but as they continue to walk, their strides improve. So many of these patients are actually diagnosed of PSP or MSA, some of these atypical Parkinson disorders, rather than actually thinking about paraneoplastic syndrome. And that's where this antibody is going to turn out to be crucial. So back when he saw me, I saw the patient. Given the presentation, I was concerned about an underlying paraneoplastic syndrome. I got a scrotal ultrasound, which just demonstrated a testicular mass. A PET scan was performed, which did not show any other tumors or any other masses anywhere else. We ended up removing the testicular mass, and what we found was not necessarily a tumor, but a burned out tumor, with clear evidence that there was a tumor there which has been sort of taken away by the immune system, and there was evidence of necrosis inside the mass and calcification. And this is sometimes what we see in patients with testicular cancer-associated paraneoplastic syndrome. Even though the immune response started against the tumor, the immune system is strong enough to kill the tumor, but this continued immune activity then starts attacking the brain, and that's what causes this progressive disorder. On the serum and the CSF samples we received, we did tissue immunofluorescence assay. And this has been our workhorse of our lab for the last 30 years. What we do here is we have these thin sections of mouse brain, where on top of which we add the patient samples. And each of the antibodies has a very specific pattern. The Kelch-11 antibody has been giving us this very unique dotted pattern in certain areas of the mouse brain, around the hippocampus of the mouse, in the region of the brainstem, and around the choroid plexus or the ventricles. And what we see are these dotted star-like signals, which we have been referring to as sparkles. And we've been collecting these samples for more than 15 years. And every time we see sparkles pattern, the story is very consistent with the gentleman we just saw, where the patients come in complaining of instability, speech changes, vision changes, and we end up finding testicular cancers at various sites. However, we had known about the pattern, but we had not known about the protein. And this is where a newer technology called as phage display, with help of our collaborators in UCSF, came very handy. What this technology is we have expressed the entire human proteome on these small bacteriophage particles, and then utilizing human serum or CSF, we can immunoprecipitate the phages with a specific protein to which the patients have antibodies to, and which on subsequent sequencing gives us the answer. And that's what led to this discovery of Kelch-like protein 11 being the biomarker of sparkles in these patients. What it also helped us with is epitope mapping. It told us what fragment of the Kelch protein are most of these patients' antibodies binding to, and it was fragment 10. most of the patients we've tested have been very specifically binding to this particular fragment, even though there is some polyclonal response, as is expected in nearly all autoimmune or paraneoplastic disorders. So by now, we realize that this is not a very uncommon disorder when we compare it to in relation to other paraneoplastic syndromes. So I did an Olmsted County epidemiology study where, since we have data for pretty much everybody who lives in Olmsted County, we looked at the data carefully to understand what is the incidence and prevalence of Kelch-11 encephalitis. And it turns out to be one of the most common paraneoplastic ataxias or paraneoplastic encephalitis we encounter, especially in males. So the male prevalence is about 2.8 per 100,000. If you extrapolate it on a world stage, it leads to thousands of cases with this particular syndrome, with having this particular antibody, most of whom are undiagnosed or misdiagnosed. The most common clinical presentation in these patients is rhombin encephalitis with brainstem predominant presentation with cerebellar involvement in majority. I've had a few cases now who've had presentations with limbic encephalitis with involvement of the temporal lobes, some of them presenting with seizures as the initial presentation, going on to develop confusion. And we've also had cases who have had both involvement of the brainstem as well as the limbic system. The one important point which I would like to make is about hearing loss and ringing in the ears. In many of these patients, hearing loss and the ringing in the ears can precede the more devastating brainstem syndrome or limbic encephalitis by many months. And just recently, we finally were able to catch one patient who just has hearing loss and vertigo as the initial presentation. Because unfortunately, rest of all of our cases, by the time we see them, they've already had a lot of brain inflammation occurring already. The other important point, which I'd initially brought up, is this antibody useful in directing cancer surge? And the answer is yes. And the cancer usually ends up being testicular cancer in more than 70% of the cases. So again, coming back to the point of the hearing loss, these are MRIs from some of the patients I have seen, where the MRIs demonstrate involvement of the cochlea, that's the inner ear, and there's evidence of inflammation there. It also shows there is involvement of the 8th cranial nerve, which transmits all the hearing sensation to the brain. These are audiometric analyses of these patients, which demonstrate these patients can have severe, profound hearing loss. So this particular syndrome of hearing loss and peripheral vertigo is called as paraneoplastic cochleovestibulopathy, which is one of the presentations for Kelch-like Kelch-11 encephalitis. The important things about hearing loss is it usually has an asymmetric onset, starts in one ear first, then transitions on to the other ear within a few weeks. It's rapid and it's refractory. So usually when patients come to the ER, they're treated with symptomatic medication. They don't necessarily get better. And then again, this timeline highlights the point that the hearing loss, which can be an initial manifestation, as mentioned in this gray circle, can precede rhombin encephalitis, which is the purple circle, by months. So like in this case, it happened, the hearing loss occurred 6 months prior to the patient developing rhombin encephalitis symptoms. Other examples as well, where acute vertigo or a vestibulopathy can precede the brainstem inflammation or cerebellar inflammation by months, even up to more than a year. So if we are able to catch these patients here, when they're actively having this refractory hearing loss and vertigo presentation, we might be able to help them even more. These are some of my patients who came in complaining of vision changes. So this gentleman, whenever he sat at the end of the day to watch a game or watch TV, what he was seeing was the entire TV move, or what is called as this oscillopsia, or illusion of stationary things moving around. So in this video, he explains when the oscillopsia starts and when it stops. And you can easily correlate it with his eye movements or nystagmus.
It'll happen.
It'll just kind of keep coming and going indefinitely.
Yep. Mm-hmm.
But it does kind of start and stop.
Yep.
Start and stop.
Definitely.
You tell me when it
It
stops.
feels like he stopped and then it started right away. Stopped. Started.
Every time he has this vertical nystagmus, that's when this oscillopsia or the sensation of things moving around starts. There's another patient who had periodic alternating nystagmus, slightly, I would say, more subtle than the last
While you're
case.
keeping your head real still, I want you to look right at this pointer.
But as he moves his eyes to the
Follow right
side,
over here.
you can see some jerking nystagmus beating in one direction. And then when he
Way
moves
over
his
here,
eyes
keep your
on the
head
other
real
side,
still.
there's a lag
Right
period.
back in the middle.
But then when the eyes are
Just
moved
follow
again,
with your eyes
there is a
again.
nystagmus in a different direction. So this phenomena, or periodic alternating nystagmus, can also be seen in many of these patients with Kelch-11 encephalitis. Radiologically, we've seen wide variety of changes, and I'll show some of them. But one important feature which I've come across is hypertrophic olivary degeneration. And most of the cases who have hypertrophic olivary degeneration are usually cases who've had the disease for many years. And many a times this may be considered as a sign that this is where the patient has reached a refractory stage, and aggressive continuous immunotherapy may not bring about a significant amount of improvement. And this happens because of inflammation in the dentatorubral pathway, which subsequently leads to degeneration of the olives. And you can see it with this hypertrophic changes we are seeing in this image with evidence of T2 or flare hyperintensity. What these patients complain of, or usually complain of, is clicking sound in their ears. And that happens because of palatal tremor. But unfortunately, given majority of Kelch-11 patients have hearing loss or hearing changes, you don't get that history. So it's extremely important to ask these patients to actually open their mouth and look at their palate to look for palatal tremor. So this is one of my patients who had this particular condition. And if you look at the palate carefully, you can see it tremoring or jerking once again. So another feature which can make you think about testing for Kelch-11 antibody. So another gentleman who came in with the diagnosis of multiple sclerosis, and this was his initial MRI. You can see a periventricular lesion on one side of the brainstem. He was diagnosed, put on disease-modifying therapies for MS, but was unfortunately getting worse. He subsequently actually ended up being admitted to our hospital because he started noticing that he could not open his mouth. He developed what is called as trisomus, where the muscles in his jaw were spasming. What was also happening was his wife complained every time he goes to sleep, he stops breathing. And this particular condition is called as Ondine's curse, where when the patients are not aware or awake and thinking about their breathing, their automatic system, which continues to allow them to breathe, stops functioning. And that's because of inflammation at the level of the respiratory center. And that's his video. And I'm just he's speaking, and you can see the trisomus or the jaw dystonia pretty evidently. Say, the president lives in the White House.
The president lives in the White House.
Today is a nice day.
Today is a nice day.
Can you open your mouth? Say yeah. Okay, relax. Open your mouth again. Okay. Try to stick out your tongue. Okay. What you can also see is he has a trach placed because of the inflammation in the respiratory center. Since his brain does not control his automatic breathing when he was sleeping, we had to do a tracheostomy. What we also had to do was place a diaphragmatic pacer, which is like a pacing device which does the breathing for him by contracting his diaphragm frequently. But we treated him aggressively with steroids, plasma exchange, and then put him on cyclophosphamide, and he's actually starting to improve. This is his MRI following his treatment, and you can see those areas of inflammation have remarkably improved. His jaw opening has also improved, and so has his respiratory drive. These are some of the other MRIs I was talking about. Interestingly, the areas where we see inflammation, the brainstem and the hippocampal region or the limbic system, are the areas where, at least on the mice sections, Kelch is mostly expressed. So there might be a correlation about regarding antigen expression and this syndrome where the inflammation is happening. So as we are seeing more and more cases, we are recognizing that this is a wider spectrum. Even though brainstem encephalitis or Raman encephalitis is the most common presentation, there are atypical presentations of this particular condition as well. So whenever you see a paraneoplastic syndrome and you're suspecting one in association with testicular cancer, but the patient's phenotype doesn't necessarily fit Raman encephalitis completely, I would still suggest to think about testing for Kelch-11. So this gentleman I saw not too long ago, he had the history of seminoma a couple of years ago. Then he started developing generalized tonic-clonic seizures and this new onset left-sided hearing loss. So the hearing loss does make sense with everything we've talked about, but the GTCs were less common in our initial cohort. He was treated with anti-seizure medications and the seizures resolved. He became seizure-free, and the MRI, that's the lesion on his initial MRI in July, which completely went away on its own without any immunotherapy. But then in May of last year, he started having recurrence of his generalized tonic-clonic seizures, and he also started having these focal seizures involving one side of the face. And let me show you a video. He was having these jerking episodes hundreds of times in a day. Not only when he was awake, but also when he was sleeping. And this was continuously going on. And when the MRI was repeated, you see that the old lesion which was there has now come back. So this is when we saw him. We have started treating him with steroids, and he showed considerable improvement in his seizure frequency. We looked for cancer. Fortunately, he does not have recurrence of cancer. And now we probably transition him to more aggressive second-line therapies. So once again, even though testicular cancer is the cancer we're talking about, it's not always found in the scrotum. That's another important point to keep in mind. Many of our cases who have testicular germ cell tumor are actually found in the mediastinum or in the retroperitoneum, where are the other common sites where germ cell tumors can hide. So in most of these patients, along with doing a scrotal ultrasound, I usually do a PET scan looking for any extratesticular mass or extratesticular tumor as well. This is a tumor from one of the patients, actually the one on the leftmost, with that hypermetabolic mass right next to his heart, where we can clearly see expression of Kelch inside the tumor. And that's what the initial expression of the protein inside the tumor is what triggers this paraneoplastic syndrome. We have seen some atypical cases as well, where we have seen this particular syndrome in association with other cancers. We've now had a lung adenocarcinoma case. Again, we took the biopsy, we made sure the Kelch is expressed in the tumor, and as you can see on the right side, there is expression of Kelch. But these are very, very rare associations. So given the growing literature and growing work around Kelch-11, many of us came together who work in the field and came up with this updated diagnostic criteria for paraneoplastic syndrome. We came up with a list of high-risk antibodies, which have a strong association with underlying cancer. Previously, the list was sort of somewhat limited, but now we've expanded it to include the more newer discoveries. And Kelch-11 is another antibody which we have included as a high-risk antibody as a part of the paraneoplastic neurological syndrome criteria. So the question which I'm frequently asked is it the antibody which is pathogenic, or is there something else which is causing the disease? So to understand this, as we take a step back and understand how exactly paraneoplastic syndromes occur, usually it's the tumor which comes first. The tumor expresses the antigen, in this scenario, Kelch, inside the tumor. And then the immune system, as it is attacking the tumor, attacks these proteins which are expressed by the tumor. and leads to formation of not just B cells, which make antibodies against Kelch, but also cytotoxic and helper T cells, which have the cellular immunity against these particular proteins. And the antibodies themselves go bind to the protein, but then since this protein is intracellular, they don't have as well of an access to the protein. But the T cells attack the protein, which is expressed by the MHC on the surface of the cell. And we think particularly for Kelch-11, the disease pathogenesis is not by the antibody, but by these cytotoxic T cells, which are causing the disease process. And we've done some experiments. We've looked at immunopathology to understand this further. So what we did was we took peripheral blood lymphocytes from patients with Kelch-11, and we exposed it to the protein. And then we did flow cytometry experiments to understand what particular cell types get changed, or what kind of activation patterns we see. And what we saw was on exposure to Kelch-11, there's clearly an autoantigen specific CD4 and CD8 T cell activation. And this is specific to a particular protein. So if we take Kelch-11 patients, PBMCs, expose them to Kelch, we clearly see a marked activation. If we expose the same PBMCs to MAR2, which is another paraneoplastic encephalitis, we do not see that. So it's again specific for Kelch. If we take MAR2 patients' PBMCs and expose them to MAR2, we do see that response, but not necessarily to Kelch. And that's what makes us believe that this is a T cell response, which is causing the disease to this intracellular antigen. What we have also done is we've done mass cytometry experiments to better understand what kind of cells are being activated by this antigen. And what we have found are these are CD8 memory T cells. So what that makes me think is it's a memory response. So even if you remove the tumor, the immune system remembers to continue to attack the protein. So the two places where the protein is found is the tumor and the brain. You've removed one of them, but there's still the second one, which is there. That's one of the reasons why these patients require aggressive immunotherapy, even after removing the underlying triggering agent or triggering factors such as the tumor. And that's why we treat them aggressively with steroids, cyclophosphamide, and other immunotherapy agents. Another thing which we have seen is this is a biopsy from one of the patients with active disease. And all these blue dots you're seeing on H&E are all lymphocytes inside the brain. And when we did more immunohistochemistry studies, and what we saw was there was a florid cytotoxic CD8 T cell response with non-caseating granulomas, which can sometimes be seen in sarcoidosis. So it's a very aggressive T cell mediated disease process. And if these patients are not diagnosed early with at later stage when the biopsy is done, or unfortunately in some scenarios when we've done autopsies, what we have found is a lot of fibrotic changes and all the neurons being damaged. So as you can see in panel A, there's no neuron in that histopathology from the brain. Those changes can be seen in the diencephalic regions, inside the cerebellum as well. As you can see, actively the Purkinje cells are being lost in this process. So it's a very aggressive disease, and it's very important disease to identify early, because that's when we can make a difference. There also seems to be an HLA association. So one of the questions I'm faced regularly is, why doesn't everybody with testicular cancer develop this particular syndrome? And there might be an answer when we start to analyze and understand these HLA or genetic associations for this particular condition. And in a very small group of patients, what we found was these patients had much more commonly HLA DR17 DQ2 haplotype. When we compared it to the healthy population in Olmsted County, it was found to be significantly different. And I think as we collect more and more patients, we'll start to learn about these HLA class 2 as well as I think HLA class 1 associations. So how do I treat the patient? The first thing is find the tumor, take out the tumor, or treat the tumor. This may require just a surgical resection. In many cases, it requires chemotherapy. But most of the time, testicular germ cell tumors, commonly seminoma, which is the most common tumor we find, is not the problem. We can easily treat that. But what ends up being the problem is this aggressive immune response, which requires more aggressive and chronic immunotherapy. So the first line agents are usually steroids, the drug of choice. Sometimes in very sick patients, I do combine it with plasma exchange. And then the second line agents commonly used are oral or IV cyclophosphamide, depending upon the patient's severity, how much swallowing difficulties he or she he has. I've rarely utilized this combination of rituximab and mycophenolate in patients who are not able to tolerate cyclophosphamide. Outcome-wise, so far, most of the patients we've seen seem to have a refractory course. Majority of them require some kind of gait aid, like the gentleman we saw first using a walker. Many of them require a wheelchair by the time they end up coming to our clinic, or even on their long-term follow-up when I've been seeing them for more than 1 year to 2 years. The median MRS is 4, again, highlighting how severe disease it is. In close to half of the patients, we're able to bring about some disease stabilization. Improvement is even less. Very few patients we've had who we've caught early enough and treated aggressively enough that we've been able to bring about clinical improvement, but there are cases. The proportion of patients who require wheelchair is higher in patients in whom no testicular cancer is found, or the patients in whom, when we find the mass, it ends up being a fibrotic, necrosed, burnt out tumor. And sometimes you can think about it that the tumor and the immune response has been there for longer compared to other cases where you can actually find the tumor and remove the tumor. And we've had 8 deaths in one of the studies we published. So again, these are Kaplan-Meier curves, which are based on wheelchair dependence or cumulative probability of being wheelchair free. Again, you can see if you know testicular cancer is found that the dependence on wheelchair seems to be higher at the last follow-up. And then if there is a testicular cancer detected, that proportion is slightly less, but still pretty significant. It seems to behave like MAR2 encephalitis in terms of long-term outcome. MAR2 is a more known paraneoplastic diencephalic encephalitis or brainstem encephalitis. So it seems to be as refractory as MAR2 encephalitis. It has been reported by other labs as well. Modis et al. Reported 32 cases. However, one of the concerns I had with this paper was only 7 of them had this tissue immunofluorescence pattern, which is kind of required for all our assays, which I'm going to briefly talk about. And 72% of those cases had tumors, mostly germ cell tumors. However, their phenotypes varied. Once again, the lack of tissue IF positivity raises some concern. Again, this is the tissue IF in the 7 patients they reported, and this is the sparkle pattern, which has been pivotal in the discovery of this antibody and is seen in every Kelch-11 patient we report. So talking about testing now. Right now, as a commercial lab, we are the only ones providing it. We screen by doing a cell-based assay, and then we confirm every patient who's reported to be Kelch-11 positive with a tissue immunofluorescence assay. That's the same assay where we have these thin slices of mouse brain, we add the patient's serum, we see the sparkles pattern, and that's how we report out titers for these patients. Currently, it's being done as a standalone test. These are the test IDs you can use to order the test in the serum or CSF. Since serum is easy to collect, we usually suggest just order the serum test, but CSF works well as well. In the future, we plan to add it to other panels as well. And right now, the turnaround times for the CBA is 3 to 5 days. So if you have a negative result, you'll receive it quickly. But if you have a positive result, it might take 5 to 10 days because then the tissue IF will be done and titrated. So the way we are going to test by CBA is through this semi-AI automated methodology, which has been sort of brought about in our lab. On Shannon and Greg are 2 people who have worked closely with me on bringing about sort of this assay. What we are doing is we are using 96 well plates using HEC293 cells, which have the Kelch-11 protein expressed in them. And then we fix and permeabilize these cells and expose them to the patient's serum and then the secondary antibody. And then what does the reading is not a consultant or a technologist, but actually the slide scanner, which actually reads the assay and gives us the result. So once again, the protein in green expressed inside the cell, we expose it to the patient's antibodies, has a secondary which can be read. And then what is generated as the result is the ratio of co-localization between this green and red and total number of green present inside the cell. And we have come up with a cutoff based on all the validation and thousands of samples we have tested to say above this, it should be considered positive. Given we're planning for the future, planning to add it into the other panel, this allows us the capacity to expand the CBA and do hundreds of these in a day in the future. Manually, this can be pretty laborious. And to give you an idea, this is some of pictures from those assays. So that's the GFP expression, the green, that's where the protein is. We add the patient's antibodies, those are the red, and yellow is the co-localization. So that's a true positive. You can see the green and red are co-localizing perfectly, and it all showing up as yellow. But one caution or caveat I always want people to keep in mind is CBA is not 100%. It's a very good screening tool. It's highly sensitive, highly specific, but there are some false positive cases we do see. So that's why wait for the confirmatory results. And that's how we have sort of included interpretations in there as well. To give you an example, this is a low false positive result where we see the green protein, but we also see some dots in red, which incidentally, if you look at this highly magnified image, these green dots, which are yellow in this picture, and then the green dots, which are blue in this picture, and then the red dots, which are yellow, tend to co-localize at certain areas. And that's what generates this ratio above 0.05 and can lead to a false positive screening result. And that's why every sample which comes as positive on CBA is subsequently reflects to the tissue immunofluorescence assay to see if there is that characteristic sparkles pattern seen or not. And two people who worked extensively on the sparkles pattern along with me are Dr. Sean Pittock, who's been sort of seeing these cases for many years, and Tom Kreiser, who was instrumental in doing all these mice sections along with me to find where these proteins are expressed. Again, the two areas I was talking about are the hippocampus and around the ventricles or around the choroid plexus. So some of these patients we have found have a coexisting antibody called as leucine zipper 4. This was also discovered at Mayo Clinic, but the technique we used to discover this antibody was different. We found a common band using a seminoma cell line, and subsequently we did immunoprecipitation mass spectrometry and found that these patients had leucine zipper 4. This also seems to be an intracellular antigen where there's an aggressive T cell response, and many of these patients, as I said, can have both LUZP4 and Kelch-11 antibodies at the same time. The patients who have a combination of these antibodies are the ones who more than 90% or more than 95% of the time end up having a testicular cancer. So like exists for ANA1 or CRIM5, some of the other older onconeural antibodies, the combination actually increases the risk of cancer even more. And another feature which we have seen is many of these patients with leucine zipper 4 seem to have a motor neuronopathy phenotype where the motor neurons are affected. As you can see in these images of the spinal cord, it seems to have inflammation at the anterior horn cell level. And there is atrophy, which can resemble and sometimes make us concerned about an ALS-like picture. So this is a gentleman whom I saw in clinic who presented with bilateral upper extremity weakness, which can resemble ALS involving both arms.
Open your hands
and that's his assessment, where he could not move his arms at all.
Okay.
So
Right,
again,
making fists,
typical presentation,
okay.
but something to
And then
keep
open
in
the hands
mind,
again.
especially when you find they have some other features to suggest some brainstem involvement, or you end up finding a testicular cancer. So to conclude, Kelch-like protein 11 is a specific biomarker of paraneoplastic encephalitis in men. It's typically associated with testicular tumor. It's an aggressive and refractory disease. And in the patients in whom we're able to find the testicular cancer, they are the ones who do better. And once again, earlier you diagnose, earlier you treat, the better our chances of making clinical improvement or bringing about disease stabilization in these patients. The way we are detecting this antibody in our lab is screening by cell-based assay using the methodology I briefly talked about, and then confirming by tissue immunofluorescence assay. And in some of these cases, we do see a coexisting antibody called as LUGP4, which increases the chance of testicular cancer. And some of these patients can have this atypical presentation, with motor neuronopathy being one of the presenting phenotypes. Thank you.
Thank you so much, Dr. Dubé. At this time, I'm going to open everything up for questions. So if you do, again, have a question you would like to ask, just a reminder that you can submit it via the Q&A function at the bottom of the Zoom. And Dr. Dubé, we do have some questions that came in during your talk. And so I'm hoping, if you're willing, we can address those right away.
Sounds good, Kala.
Wonderful. So the first question is, what percentage of patients with the Kelch-11 have abnormal findings on the brain MRI?
I think that's a great question. Because it's actually the minority. So less than 50% actually at the onset, when they come to our clinic, have abnormal MRI findings. And that's one of the many other reasons why some of them end up being misdiagnosed, because once we see normal MRIs, sometimes we don't think about inflammatory conditions affecting the central nervous system. But as the disease progresses, most of them develop either hyperintensity involving the brainstem or cerebellum, or the most common presentation I've seen over time is clear cerebellar atrophy.
Okay, and I have I think it's a bit of a follow-up to that as well. So in your practice, when you're screening for associated malignancies, do you typically pursue a whole body PET scan first, or have you found that there's any role for the CT CAP prior to a whole body PET scan?
Another good question. I think some of this is dictated by the insurance, and the others are dictated by how much data we have on the patient. So for example, if there's not necessarily going to be an insurance issue and the patient does have an underlying high-risk antibody, I have a very low threshold to go directly to PET scan. Some of the scenarios where I find especially high resolution CT can be helpful is cases where I'm thinking about a thymoma, because sometimes PET scans with thicker sections can miss thymoma. So those are the cases I actually think about doing a high resolution CT as well as a PET scan. And then once again, to highlight, PET scans are horrible to catch testicular cancer. So in all of these cases, I make sure to do a scrotal ultrasound. Other scenario, which is kind of PET scans are not as good at, is ovarian teratomas, like in an NMDA receptor encephalitis. And those are where I tend to do transvaginal ultrasound in those patients.
Thank you so much for that. The next question I have is, MA2 and KLH11 are both prevalent in males and indicate potential for testicular cancer. Will Mayo be offering MA2 in the future along with Kelch-11?
We are actively working on that. I think MA2 is a very important and relevant antibody to this field. And in the future, we are hoping to offer MA2 as well as a part of the panel or as a part of sort of this testing algorithm.
Thank you for that. So that actually leads into the one of the last questions that I have is, this particular test is currently offered as standalone. Mayo is known for its traditional panel or algorithmic approaches. Will this be added to any of our panels or algorithms in the future?
Yes. So so this is a new technique, and we wanted to gain some experience in the technique before we expand the test to the other relevant panels. But most likely by the end of this year or beginning of next year, we'll introduce this in the autoimmune movement disorder panel, because that's the most relevant panel given patients have ataxia and other movement disorders, and potentially in the future, introduce it to other relevant panels as well.
So you talked about in the beginning of your presentation how common this protein really is in the general population. And you had mentioned over the course of your talk that it's sometimes misdiagnosed for other autoimmune diseases. Can you just review How frequently was it either missed or misdiagnosed that you're finding now that you're identifying these patients?
Yeah, I think as I was initially working on the initial papers, it did sort of, it took me by surprise how often people were thinking about MS, brain tumors, infections as the potential diagnosis rather than thinking about paraneoplastic syndrome. However, I don't blame the physicians who were seeing these patients because this disease did not exist. The disease has been defined by the biomarker, and all we knew about was the clinical presentation. And this presentation being, as we are recognizing, being wider, it was difficult to diagnose clinically. So in majority of the cases we saw, the initial diagnosis was not a paraneoplastic brainstem encephalitis, but an alternative etiology. Rather than using the word misdiagnosis, I would prefer to use the word an alternative diagnosis was suspected because, again, the antibody did not exist. And it's very hard for clinicians to kind of think about this when there's not necessarily a biomarker, once again, highlighting how useful this antibody can be in helping many of our patients.
I think it just really highlights that in medicine, we're always learning and it never ends, does it? I have one more quick question for you. So if Kelch-11 is not ordered separately at the onset, what is the chance that it could possibly be reported or caught at the IFA screen from some of our panels?
That's an excellent question by Dr. Piquet, because it has been challenging to pick these sparkles pattern on the tissue IFA on patients in whom a paraneoplastic panel or an autoimmune encephalitis panel was sent. As you can imagine, these are small dots in couple of specific areas of the brain. And as we are screening through hundreds of thousands of slides every day, sometimes these small dots can be missed. And that's probably one of the reasons is as we are starting to do CBAs in patients more regularly, we are seeing more and more and more patients. I hear about at least 1 or 2 patients every couple of weeks, which with the new diagnosis. So it's possible that if you've seen patients in the past which resemble this phenotype, and you had ordered a paraneoplastic panel, it's possible that we might not have seen the pattern or recognized the pattern and reached out to you. So that's another group where even in hindsight, if we are thinking about Kelch-11, those are the patients which should be tested or now could be tested.
Understood. So there is a potential to take those patients that you maybe didn't have, a full picture of before and do this testing again on them to see if we find something on them that we didn't catch yesterday.
So, for example, if the paraneoplastic panel was sent in 2016, came back negative, but still the picture looks like Kelch-11 encephalitis, I would suggest those might be the patients to possibly send specifically looking for Kelch-11.
No, it's good to understand that that's a scenario and an option too, to go back and look at those patients that we've seen previously. I have one more question that came in. So it says, for your approach to treatment of Kelch acutely, you mentioned that you select IVMP plus or minus Plex. Is there a reason why IVIG is not an alternative to Plex in your practice? Is it related to severity of disease or needing a quicker onset of disease management?
Another very helpful and very important question. I think it's more related to the disease pathogenesis. And we feel confident that Kelch is a T-cell mediated syndrome. And since IVIG, as we're learning about it, some people think it works through FcRn receptors by depleting pathogenic antibodies. In my experience, it does not seem to bring about as much of a benefit in these syndromes when used as a first-line therapy. That's why I tend to lean towards IV Solumedrol, which is this widest spectrum of mechanism of action first. And the Plex, the more utility of Plex is not just removing the antibodies, which are probably not doing much, but more importantly, removing the cytokines and chemokines, which are activating these T cells and causing the disease process. So that's why the first line is always steroids, sometimes combined with Plex for that additional benefit. But I tend to stay away from IVIG in managing these patients. At least I've sort of used it less and less. And the patients which have been treated with IVIG have not really seen a biggest bang for the buck.
Okay, thank you. I think that's really helpful. So with the one patient that we saw and caught early that really presented with just the hearing loss only, you had mentioned that he was treated with immunotherapy. And did that prevent development of any of that brainstem or cerebellar involvement that we've seen with some of those patients who had probably progressed a little more before they came into your clinic?
So I'm going to see this patient next month as a follow-up. So I will find out soon. I hope so. We've had some other cases where even though they had brainstem encephalitis features, it was mild. Their hearing loss was more profound. And in those cases, we have seen that early immunotherapy has actually brought about significant enough relief that they can actually go back to their jobs and their regular life despite having this disorder. Again, as you can imagine, this is a disorder which happens in the 20s to 30s to 40s age range. So these are the people who are in the most productive phase of their life. So it's extremely important for us to stabilize or bring about improvement in these diseases. And as was rightly mentioned, catching early is the answer.
Thank you. So I have a question that actually goes back to the testing itself. Is there any difference or increased sensitivity or specificity between the two sample types, between the serum or the CSF?
We haven't clearly found a significant enough difference between the serum and the CSF. We have a lot more experience with serum. We've tested thousands of them by now. So it works very well. And especially with this two-step approach of CBA followed by tissue IFA, it adds this extra level of sort of specificity, which helps make sure that we're not generating false positive results. So sending serum, which is easier to send in most cases, is also okay.
Thank you. So you've talked a lot about the diagnostic value of this marker and making sure that we're appropriately finding these patients. Have we found at this point, and I know that this is a little bit newer, but is there a prognostic value to identifying these patients early as well?
Yes, because I think we can have that frank discussion with the patient based on the data we have to understand realistically what outcomes we are looking for. So in these different autoimmune diseases, the outcome or the natural histories are very different. So when I see these patients, I clearly mention to them that as I'm going to actively treat, our goal is going to be to stop the disease from getting worse. Whatever benefit we get at the end of this immunotherapy would be additional and would be a bonus. So the goal, as we have seen, these are very refractory. This is a very refractory condition, very aggressive condition, and the goal is to prevent the progression. That's what we know in terms of the prognosis. It's a hard disease to treat. And sometimes I've had cases we've tried everything, including combinations of cyclophosphamide, rituximab, looked for tumor everywhere and haven't found it. And unfortunately, there are some cases who continue to have a progressive course. And this is not just specific for Kelch. We've seen it in other classic paraneoplastic conditions as well, such as anti-Yo paraneoplastic syndrome or anti-Re paraneoplastic syndrome, which can also have these outliers which are extremely refractory.
So thank you so much, Dr. Dubé, for answering all of our questions. So we're running short on time, so I am going to go ahead and just thank everybody for coming today and participating in our discussion. There may be a question or two that's come in that we haven't had time to answer. We will get to those questions, and what will happen is after this webinar, you will receive an evaluation that will be forwarded to you, and you can ask any additional questions or let us know if there's something we didn't get to today that you still want us to answer, and we will make sure that we do that. Also, I just wanted to note that laboratory credit is extended for this program. So upon finalizing your evaluation, you will have the option to claim credit and print your certificate. And then again, this program is recorded. So in a week or two, it will be up on our website and you will be notified of that as well. So I just wanted to say thank you again, Dr. Dubé, for the wonderful talk. And thank you for answering all of our questions. This was really enlightening and I learned a lot today and I appreciate your time.